Let us now move forward with track 3 of our conference. The theme of this session is early recognition of clinical deterioration, a key determinant of outcomes. This crucial topic emphasizes how timely identification can greatly impact patient outcomes and quality of care. This session will highlight the importance of vigilant, prompt response and how early recognition directly influences patient safety and overall outcomes. To lead us through the enlightening session, may I now invite our esteemed chairperson, respected Madam Professor Dr. Babita Vaishya Dekab, Professor, Apollo College of Nursing, Guwahati, Member, ANEI. I also invite respected Sir Dr. Gaurav Gupta, Associate Professor, Department of Pediatrics, AIMS, Guwahati, to discuss the topic in depth. I also welcome Madam respected Ms. Banri Corder Khairiam. I now request Banri Corder Khairiam, Nursing Officer, NICU, AIMS, Guwahati. I now request our respected chairperson to kindly come up on the stage and open the session for all. I request the ANEI members to kindly escort them.
Very unique and they are very special. We have to look after them very uniquely. The alteration in their signs and symptoms may lead to some physiological changes, and when they go to the state of criticalness, it is very difficult for them to revive. So we have developed a lot of measures to do the scoring of how they get deterioration, and early recognition can bring back the child and have a good outcome for in the treatment process. So in the beginning, I'd like to request Dr. Gaurav Gupta, Associate Professor, AIMS, Guwahati, to start his topic with these words.
Thank you, ma'am. I would like to thank organizers, ANEI and College of Nursing for inviting me to speak on this very important topic, and I would like to emphasize the importance of this topic also. So first of all, I wanted to share you one thing. Like as the theme is there, so why it is very important. So we will discuss today like what is the early recognition, how to do early recognition of clinical deterioration, and also case-based discussion on some U's and P's. Okay. So how many of you know about what is PUs and what is BUs basically? They are actually clinical tools. Okay, they are the early warning signs which have been done and for adult patient for MUs and for pediatric age group to detect them early clinical deterioration. Now we come to one thing. Why it is important? First importance is that they can actually prevent the severe adverse effect like unplanned ICU admissions and so basically in 70% of the in-hospital cardiac arrest who have a documented signs of clinical deterioration in hours leading to event, we can prevent around 70% of those cardiac arrests by recognizing these early signs. And studies have also proven that even ICU admission can reduce up to 30% and highlighting the importance of prompt action when these warning signs arise. So there are basically early warning scores are those bedside tools which is excuse me. Okay. So why it is important? Like immediate assessment or prioritization is needed, and because there are two things which are more important. First is the vital signs. So vital signs are the 4 things which you have to look for early deterioration, which include respiratory rate, heart rate, blood pressure and oxygen saturation. As we all know that we have to see for tachypnea or bradypnea. Tachypnea could be an early feature of metabolic acidosis or respiratory distress. However, heart rate, first thing is that tachycardia. We know that shock usually manifests as a first initially as a tachycardia. So there could be features of early shock or could be features of some dehydration. And bradypnea may lead to, it could be impending signs of cardiac arrest. And blood pressure, we have to look for any initial for any late, which is a late sign of shock, to any narrowing of pulse pressure, and definitely for hypoxia. If the oxygen saturation dips less than 90%, then we have to be very much sure if the patient is actually sick or not. So we have to look for those warning signs also. Again, coming on to the assessment part, which is the foremost important is the neurological status. If any patient deteriorates, the first thing is that there will be change in the confusion or delirium, or there will be change in the Glasgow Coma Scale, which have to be monitored regularly. And if there is any seizure-like activity, or we have to see the pupillary response because the child may have a neurological damage or brain herniation. And seizure-like activity can be due to some electrolyte disbalance or intracranial pressure changes. So, and coming on to the other parts, like it could be other like physical and skin changes. They are very much important because cold and clammy skin can be the early feature of the vasoconstriction and early features of shock actually. And capillary refill time is foremost also important because blood pressure, you may detect changes in the blood pressure later, but this capillary refill time will be you will be able to assess capillary refill time early in case of early shock. However, BP may not be normal during when this CFT increases. So that's why CFT has a much more importance than blood pressure, specifically in the children. So that's why we have to see for capillary refill time. And it could be like if they are having some babies might be having some circulatory issues, and capillary refill time will be the first thing which will be raised, and then there will be hypertension. So there are the other signs which include the GI signs, which include abdominal pain or distension. There may be a sign of any obstruction, bleeding or perforation, and if there is a nausea and vomiting, then it could be features of increased intracranial pressure. So now important aspect is that how to escalate care in these situations. Important thing is that we have to see for 3 cardinal changes, basically 3 cardinal features to look for escalation of care. First is the unstable vital signs, which include, as I told you earlier, heart rate, changes in the heart rate, changes in the blood pressure, changes in the respiratory rate or oxygen level. And second thing is the responsiveness to the initial treatment. Like if you have given oxygen supplementation, you have to see how the child or baby is responding to them. The child is responding to any fluid resuscitation or not. And it's a time to call for then additional support. And third thing is that the changes in the neurological status. Like if there is any neurological state like confusion, agitation, drowsiness, that requires an immediate attention, and we have to see the escalation of care if any of the features we have to see if we are seeing in a baby or in children. Now there are some objective and scoring, okay, there are some structured scoring to detect those clinical deterioration in children and even in adults actually. So they are based on the early signs of the clinical deterioration. They are based on actually vital signs, clinical parameters, and they also help in the aid in the escalation and communication gap. So we are using actually modified early warning scoring. They are mainly developed for adult patients. They have certain parameters which you have to look. They have objective assessment and objective scoring of these parameters, which include heart rate, respiratory rate, blood pressure, temperature and consciousness, which can be assessed by ABPU scale. Now what are these modified early warning score? So they have actually a color coding system, and because of this color coding system they have assigned these 4 or 5 parameters into different zones like red zone, orange zone, yellow zone and blue zone. Blue zone is relatively safer. Yellow zone means you have to do some prompt evaluation, and orange zone means there will require escalation of treatment, and red zone means the child may require PQ admission, and it is indication for prompt evaluation and prompt treatment response. So respiratory rate may vary from less than 9 to more than 30. More than 30 lies in the red zone, and heart rate may vary from less than 40 to more than 130. The systolic blood pressure may rise from less than 70 to more than 200. Temperature is less than 35, comes under that orange zone, and more than 38.5 again in the orange zone. So basically this color coding system is used to for early evaluation for prompt response. And blue coding is usually, if we have to follow up also, we can have if the child lies in the total cumulative score, lies in the blue, then we have to follow up for 24 hours. If it is in the yellow zone, then we have to follow this again charting for 8 to 12 hours. If it is in the orange zone, then 4 to 8 hours is necessary for repeat charting. And if it comes in the red zone, so again this red zone is indication for the PICU admission. And if the child is also in the ward in the IPD, then this, if the child comes in these, this is for adults. If the adults come in this zone, then it's need for that, like for ICU admission. Now coming for the most important part which aligns with today's theme is the pediatric early warning scoring system. This is why it is important. They are the actual clinical manifestation which indicate a rapid deterioration in the pediatric patient. They help us to determine if the child in the emergency department should be admitted to PICU, or if the child is admitted to floor in the IPD, they could be transferred to PICU. So basically it's again a structured and objective scoring. Now it's good. So basically, again an objective scoring. So basically what I was telling, pediatric early warning signs, they are the clinical manifestation which include the rapid deterioration in the pediatric patient, and PICU score is an objective and structured score which is used to help to determine if the child is in the emergency department, if the child needs admission to directly to PICU, or even if the child is in the IPD that requires PICU admissions. And the important aspect is that it enhances the staff communication and empowers the recognition for those who are deteriorating patients. So these pediatric early warning signs include behavioral changes, cardiovascular changes, and respiratory parameters. So they include the typically scoring in these three clinical domains. So basically, and behavioral, they see for level of consciousness, cardiovascular changes like heart rate, capillary refilling time, and for respiratory parameters like respiratory rate, breathing effort, and FiO2 requirement. And each indicator is assigned for a numerical score, and total score correspond to again the escalation protocol. A low score around 0 to 2 may indicate child's condition which is in a stable condition, and high score like more than 5 and more than 6, that means that child requires immediate attention and may trigger a transfer to PICU unit or pediatric intensive care unit. So these are the pediatric early warning scoring. Again, it is a color coding system. It is used for for 0 is being assigned for a green zone. For cardiovascular thing, we usually see for capillary refill time. And in case of red, there will be capillary refill time will be more than delayed for more than 5 seconds. Tachycardia will be more than 30 above the normal rate, and there will be bradycardia also. If these features come, then child will be in the red zone and score will be aligned as 3. For respiratory parameters again, if the respiratory parameter is in the established, then it is the baseline. If there is no detection, child is in room air, we assign a score of around 0. If the respiratory rate is more than 30 above the established baseline, there are severe detections and grunting is there, or even FiO2 requirement is around 50 or 50 more than 50%, then we label in the red zone and we score as a 3. And for behavioral aspect, if the child is playing, appropriate, sleeping, then we score as 0. And if the child is lethargic, confused, and having reduced response to voice and pain, then we assign the score as the 3. And we usually do the cumulative scoring of all these 3 parameters, and based on these cumulative scoring, we assign the child on the green zone, yellow zone, orange zone and red zone. So basically in the green zone we just have to vitals, we have to reassess the vitals, we have to do the charting updates and continue the care actually. But in case of yellow zone, which is actually a subtle changes in the vital parameter, these three parameters, what we have to do, we have to we consider our plan of care, and in case of orange zone, we have to do frequent vital monitoring, and we have to ensure this repeat Q score again to be done within 30 minutes, and plan of care definitely will change in the yellows in this orange zone, while if the child comes in the cumulative score comes more than 6, that means repeat Q scoring should be done within 30 minutes. Every hour vital charting should be there, and possible transfer to PICU is required, and child is that clinical condition of child is not stable, and we have to inform the PICU team and immediately transfer the child to PICU actually. So basically this PU score has a variable component, and various meta-analysis has been shown that if we are using objectively PU scoring, then it decreases the chances of mortality, and it decreases the chances of emergency codes like code blue also. So this has been published in the recent systematic reviews also, and they have been found that those healthcare facilities who are using these objective score have decreased chances of mortality and decreased chances of PICU admissions. So we come to the case-based scenario on the basis of this pediatric early warning scoring. So first thing is that, as we have already learned, suppose a 4-year boy is there who is admitted with mild virus illness. So we have to again assess for these three clinical domains. What is the behavior? Baby's behavior is playful, normal, then we'll chart as a PU scoring as a 0. And with the cardiovascular changes, color is pink, heart rate is okay, normal 98. Then the PU score is again 0. And respiratory rate is again 20 per minute, which seems normal. There is mild distress but with minimal detection. FiO2 requirements are around 21%. So, so we will score as a 1, and then the total PU score will be 1. So what will be the plan of action for those? How will we continue the care? So there will be only routine monitoring is required. The child is stable and no additional intervention is required because PU score is coming as around 1. Okay. Now again we come to the a grave scenario in which we are doing a PU scoring. A 7-year-old girl with pneumonia and worsening respiratory distress, it came into emergency, and we have just see for this PU scoring charts, and behavioral like it's coming like lethargic, which is less responsive to pain. So PU scoring again in that domain is coming around to be 3. In cardiovascular changes, there is tachycardia, capillary refill time is 4 seconds, there is grave, but however there is no modeling, so we will assign PU score as a 2. And then there is a respiratory rate, which is tachypnea is there, 45 per minute, which is tachypnea for this age group, and there is marked distress, accessory muscle use, FiO2 requirement is around 40%, but it is not actually crossing 50%, so again we have assigned as a PU scoring of 2. So the total PU scoring comes around 7. So what will be the intervention? What will be our plan of action? Anyone? So as I told you earlier, if the total PU scoring more than 5 or 6, then that means that requires an urgent intervention, physician and PICU team to be notified, and there is a high risk of clinical deterioration. So by these objective scoring, we can just manage and stratify actually children who could be managed in IPD or who required intensive care. Now again one case about the MUSE or modified early warning score, which is usually done for adult patient. A 60-year-old post-operative patient is there, comes after appendectomy, and heart rate is around 78 per minute, which is normal for that age group. So MUSE scoring we have done 0. For respiratory scoring we have done the respiratory rate is 16 per minute, up to 14 is 0, and then after that for 15 to 16 and it becomes 1. So MUSE scoring is around 1. Blood pressure is around 128, 5 by 78, which is normal as per that age group. So MUSE scoring comes around to be 0. And temperature is again seems to be normal, so MUSE scoring around 0. So total MUSE scoring and consciousness with alert, so again it is 0. Total MUSE scoring comes down to 1. So our plan of action will be the routine care, like stable, routine post-op care monitoring and standard monitoring. So by coming on to the like signifying the importance of this case scenario, these early warning scoring system, we have came across by using this structure pattern, we can identify children and even adults who require early intervention. So, what are the barriers and challenges actually? So, by implementing these things, there are certain barriers which came across like many institute or even many unit. There are certain like there is delay in the communication or lack of standardized protocol in the units. If we are not, they do not have a standardized protocol. Then they might not be using these use scoring system. And the important aspect is the staff training there. Staff has to be trained in this so have a better outcome and for better safety management of the patient. And if there is a inconsistent monitoring practices, because this require vigilant monitoring and diligent practices. So it could be like if there is inconsistent monitoring practices, then these are some barriers and challenges while implementing these objective scoring. So coming on to conclude my session, what are the takeaways from today's session? Like early recognition of deterioration basically saves life. Mu and Q scoring provides structural assessment and timely escalation and communication are actually critical. Qs provide unplanned PQ transfer. If you do the Q scoring correctly, then it reduces the PQ transfer and PQ's admission and it decreases the mortality also. And for MUs, which is usually based on adult setting, it predicts the ICU admission and again it decreases the mortality. And both will improve the outcomes and optimize the patient's safety and management outcomes. So with this, I would like to conclude this session. These are my references. And I would like to invite Banvi. She is our nursing officer. She will proceed with team-based simulation concerned with respect to the PU scoring or pediatric early warning scoring. So thank you very much.
Event here. As we know, patient safety is something that we should all be passionate about and we should be committed to. So in today's session, as we've seen that Sir has explained about the importance of recognizing early deterioration signs and also how standardized tools like PUs can help us recognize these subtle changes, these early recognition signs for better management. And as Sir has shown like some case studies on pediatric age group, and PU score can also be like different for different age group in pediatrics, since we know that the vital parameters can be slightly different for different age groups. So Sir has shown some case studies on the pediatric age group. So to further exemplify this, we the nurses from NICU AIMS Guwahati would like to present another case scenario. And to begin, I would first like to introduce my team. I am one reporter here, and the team includes Ms. Arendita Saharia, Ms. Nida Pintingania Isuchiam, and Ms. Parikinti Rinja. So we'll begin with the first scene. In the first scene, Nurse Bari is posted in the postnatal ward, and among her patient assignments, she has been assigned baby X. So baby X is a 3-day-old boy baby born at 39 weeks gestation. His mother had had prolonged rupture of membrane, and the baby has some history of poor feeding, though the baby is feeling slightly better now. And the baby has also been under phototherapy, but at present the baby is at his mother's bedside. At 8 a.m., Nurse Bari checks on the baby.
Good morning. How is the baby? The baby is sleeping. Okay, let me have a check on the vitals. Okay, since you told that the baby is always sleeping, so you wake him up and feed him, okay? Okay, the temperature of the baby is 36.5, which is borderline but still normal. And rate is also 155, a little bit higher from previous reading, but still normal. And respiratory rate is 55, and baby is sleeping. Seems okay only. Let me check on another baby.
Okay, since the baby's vitals were all under normal ranges, Nurse Buddy decides to do her other assignments. She proceeds to other assignments and she decides that she will come and check on the baby again after 4 hours, as is the policy in the ward. And after some time, the attending doctor also asks her how is the condition of the baby.
The baby vitals is stable, and baby vitals are stable, and baby is also fine.
Do you have any concern, Nurse Buddy?
So baby at present sleeping, and though the baby have poor feeding, well, I have explained the mother and helped her in breastfeeding.
Is there any signs of distress or anything?
No, sir. At present, there's no concern like that.
So Nurse Buddy continues with her task and goes and checks the baby eggs at around 12 o'clock.
How is the baby activity at present?
The baby is always sleeping even while feeding also.
Even now also, the baby is like that? Okay, I'll just check on him again.
Nurse Buddy checks on the vitals and she's more alarmed this time.
Oh, the baby temperature is 35.8. Heart rate is also 170. And extremities are also cold. Respiratory rate is also 68. Capillary refill time is also 4 seconds. I should inform the doctor. Hello sir, I'm calling from postnatal ward. Actually, there's a baby X, his vitals are not stable. Baby temperature is also 35.8. Heart rate is also 170, and respiratory rate is also 68. Capillary refill time is also prolonged, and baby look lethargic. Please have a look on the baby.
So the doctor notes that the doctor advised that the doctor is coming immediately and that these are very concerning signs and we have lost some precious time. In the next scene, we'll continue. So in this scene, again, it's the same baby in the postnatal ward. Baby is a 3-day-old baby born at 39 weeks. Mother had prolonged rupture of membrane. Baby had some poor feeding, though is slightly better now. At 8 a.m., nurse Anindita checks on the baby.
Hello, good morning. How is your baby doing?
The baby is sleeping.
Okay, I'll check the vitals of the baby. Okay, baby's vitals look fine only. I'll check on the baby after some time. So now the baby's temperature is 36.5 degrees Celsius. Heart rate is 155 per minute. Pulse rate is 55 per minute. Baby is looking a bit pale and CRT is also 3 seconds. The baby's Pew score is at 3. So I need to monitor the baby hourly and inform a senior nurse.
So on informing, it was decided that the doctor will be notified and we will have to do a reassessment. So even though the vitals were all under normal ranges, but the Pew score showed that the Pew score is 3, so there is at least a low risk. So on reassessment,
Just 1 minute, Bandit, I'm interrupting. We have a little short of time, so please go first.
on reassessment, nurse Anindita has checked the vitals and she will now see what's the vitals now.
So after 1 hour of assessment, the temperature of the baby is 36.5, heart rate is increased to 158 per minute, respiratory rate is also 60 per minute, baby is also having subcostal and intercostal retraction. So now the Pew score is at 6. So I'll have to inform the doctor. So, Doctor, I'm Nurse Anindita from postnatal unit. I'm calling regarding the patient baby X. The baby's Pew score has increased from 3 to 6 in 1 hour. And the baby was born at 39 weeks of gestation. His mother also had prolonged rupture of membrane and baby has been having poor feeding. Now the baby is also having respiratory distress and tachycardia. Baby's CRT has also prolonged. Can you come immediately and check on the baby?
Okay, so in these two scenes, if we compare, we see that in the first scene, the vitals were normal, so the nurse keeps doing her job and checks the baby according to policy. But by then, the baby had deteriorated. But in the second scene, because we are using the Pew score, even though the vitals were in normal ranges, we were able to catch, because we have used numerical objective scoring, we were able to catch the early deterioration signs. And also in the second scenario, Nurse Anindita has used a standardized way of communicating, thereby she was able to explain the urgency to the attending doctor, and in doing so, we were able to initiate treatment faster. So in conclusion, I would like to say that Pews empower nurses to act and communicate effectively, leading to faster interventions and ultimately better patient outcomes. Thank you.
Thank you, Bandri and her group, for the role play, I say. And as she has summed up her topic, the nurses are placed in a unique position to identify the sign of deterioration in children and to respond appropriately. As Dr. Gupta has already explained very elaborately the scoring system, and it is it is a very vital role the nurses are playing in taking care of the neonates and the children. So changes in vital signs and behavior indicating the decline in the patient has to be monitored by the nurses at the early point, including the emergency departments, the children wards, and when and where, how they have to, when they need the transferring to ICU. All this has to be monitored very regularly to keep the children in a the recovery from the illness in a faster manner. So since we are running a little short of time, I would like to sum up here, and I'd like to thank Dr. Gupta and also Ms. Bandri for an excellent and elaborate presentation on the topic. Thank you so much.
A key determinant of outcomes. We have explored how timely detection of warning signs, accurate monitoring of vital parameters is highly necessary and is the backbone of patient safety. The contributions given by the resource persons have given us both practical strategies and compelling evidences, and the role play is a thorough insight. I now take a moment to honor our distinguished resource persons for their invaluable contributions. I kindly request Madam Ms. Aparajita Goswami and Madam Ms. Y. Chano Superior along with Madam Susan Yamben to kindly come and do the honors.